Good afternoon, everyone, and thank you all for joining the American Heart Association and Pima Heart and Vascular today to learn about ways to prevent cardiovascular disease. My name is Mackenzie Neff, and I'm the Executive Director for the Southern Arizona Division of the American Heart Association. The mission of the AHA is to be a relentless force for a world of longer, healthier lives. And during these uncharted times, we've discovered wonders within ourselves, wonders within our community and science. With the support of community partners like Pima Heart and Vascular, we're able to increase awareness around cardiovascular and stroke throughout Southern Arizona. When we come together as a community, we show how resilient, relentless, and unstoppable we truly are. So I'd like to take this opportunity to introduce each of you to our speaker for today. Dr. Samir D'dahl, who's a cardiologist with Pima Heart and Vascular and has over 25 years of experience in the cardiology field, is going to be educating all of us on primary prevention of cardiovascular disease. Dr. D'dahl, I'm going to hand it over to you.
Thanks, Mackenzie, and thanks to the American Heart Association for hosting this along with Pima Heart. We'll start off. So for today, I wanted to talk to everybody about the primary prevention of cardiovascular disease. And since this is a pretty diverse group, I thought perhaps the best thing to do is to go through the current guidelines so that the general public, or if there are any providers online, everybody can benefit from the talk evenly. The top 10 take-home messages from the 2019 primary prevention guidelines are as follows. The most important way to prevent atherosclerotic cardiovascular heart disease, heart failure, atrial fibrillation, pretty much all sorts of heart disease, is to promote a healthy lifestyle throughout life. We do a lot more invasive procedures and surgeries than most other developed countries, but if you look at the long-term morbidity and mortality, it's almost the same because they focus a lot more on primary prevention. Team-based care approach is an effective strategy for the prevention of cardiovascular disease. Clinicians should always evaluate the social determinants of health that affect individuals to inform treatment decisions. As you'll find out, we don't all have access to the same resources, hence the need for the team-based care approach. Adults between the ages of 40 and 75 years of age who are being evaluated for cardiovascular disease prevention should undergo a 10-year risk assessment and have a direct discussion with their providers before starting pharmacologic therapies or medications for high blood pressure, cholesterol, or with aspirin for primary prevention. And in addition, assessing other risk-enhancing factors, which we'll go through, can help guide the decision about preventive interventions in selected groups. All adults should consume a healthy diet that emphasizes intake of vegetables, fruits, nuts, whole grains, lean vegetables or animal protein, and fish, and minimize the intake of trans fats, red meats, and processed meats. Also minimize refined carbohydrates and sweetened beverages. For adults with overweight and obesity, counseling and caloric restrictions are recommended for achieving and maintaining weight loss. As far as exercise, the latest recommendation is for at least 150 minutes per week of accumulated moderate intensity physical activity, or 75 minutes per week if you are doing high intensity interval training or vigorous intensity physical activities. For adults with type 2 diabetes, lifestyle changes such as improving their dietary habits and achieving exercise recommendations are extremely crucial. When medications are indicated, the primary providers and the endocrinologist usually will start with metformin and progress to other classes of medication. all adults should be assessed at every healthcare visit for tobacco use, and those who use tobacco should be assisted and strongly advised to quit. Most patients worry about lung cancer with tobacco, but cigarette smoking is the #1 cause for heart disease in this country. Aspirin, and this is for primary prevention, this is not for patients who have established cardiovascular disease, should be used infrequently in the routine primary prevention because of the lack of net benefit. Statins, which are medications that we use to decrease cholesterol levels, is the first-line treatment for primary prevention of atherosclerotic cardiovascular disease in the appropriate patients who have high levels of LDL, which is the bad cholesterol, patients with diabetes between the ages of 40 and 75, and those who are determined to be at sufficient cardiovascular risk after discussing their risk profile with their providers. And last but not least, non-pharmacologic interventions are recommended for all adults with elevated blood pressure or hypertension. And for those who require treatment, the target blood pressure should generally be less than 130 over 80 millimeters mercury. So moving on to the prevention efforts on a global level, the examples for the social determinants of health to help prevent atherosclerotic cardiovascular disease are many. Some of them include the routine assessment of psychosocial stressors and provide the appropriate counseling. Health literacy should be assessed on average every 5 years to maximize recommendation effectiveness and bring the point home as frequently as possible. As far as diet, the things that we already discussed, in addition to the modification, body size perception and social and cultural influences should also be assessed. Potential barriers to adhering to those things include food access and economic factors, particularly in vulnerable populations and individuals that live in inner cities or rural environments, or those with advanced age that cannot go and either afford or be able to get food that is healthy on a regular basis. As far as exercise and physical activity, we always try to hammer the point with our patients about the need for this, but globally, we should be looking at other things that inhibit patients from performing exercise, such as neighborhood environments and access to facilities. In obesity and weight loss, in addition to lifestyle counseling, we need to be talking about psychosocial stressors, sleep hygiene, and other individual barriers that might be causing some of this. In diabetic patients, environmental and psychosocial factors, including depression, stress, social support also should be routinely addressed because all of these things have been shown to improve glycemic control. In high blood pressure, things as short sleep duration or poor quality sleep are also one of the risks that should be looked at. In addition to access to healthy low sodium diets and ability to exercise. With tobacco, social support is another potential determinant of tobacco use. Therefore, adults who are smokers need assistance and arrangements for individualized and group social counseling as recommended. Assessment of cardiovascular risk, we'll go through that as the lecture goes through. On the left here, you see COR stands for class of recommendation. So anything that's a class 1 tells us that there's enough evidence that has proven that this is an intervention that will improve long-term mortality and morbidity. Class 2A, the evidence is there, but not as strong. Class 3 is where the evidence shows that if you perform this or don't perform this, you can cause harm. So the class 1 recommendations are adults, again, between the ages of 40 and 75 years of age. Clinicians should routinely assess their traditional risk factors using a 10-year pooled cohort equation to do that. And for younger patients, it's reasonable to assess this every 4 to 6 years, so on average at 5 years. For borderline patients or patients in the intermediate risk that's defined as more than 7.5 and less than 20, it's reasonable to use additional risk-enhancing factors to guide decisions about preventive interventions, such as starting cholesterol medications. And we'll go through these risk-enhancing factors shortly. In the intermediate risk group and selected adults that are borderline, the risk-based decisions for preventive interventions remain uncertain. And in these patients, there are other factors or tests that we can use to be able to downgrade or upgrade the risk and have a better conversation with the patients regarding those treatments. In younger patients between ages 20 and 39, and those patients between 40 and 59 who have less than 7.5% 10-year risk, estimating a lifetime risk or 30-year risk may be considered as a better marker. So the risk-enhancing factors that I was referring to are basically starting off with family history. Anybody with family history of premature atherosclerotic cardiovascular disease, that should be taken into consideration when you're looking at their overall risk. A lot of the calculators don't use this, but it's something that needs to be added to the formula. And that's defined as a family history of a first-degree relative, a male less than 55, or a female less than 65 who suffered a cardiovascular event. Primary hypercholesterolemia, defined as bad cholesterol, LDL, between 160 and 189, or the non-HDL between 190 and 219. Metabolic syndrome, and the list goes here. You need 3 of these markers to diagnose a patient with that, basically central obesity, high triglyceride levels, elevated blood pressure or glucose, or low HDL, which is what we refer to generally as the good cholesterol. Also, patients with chronic kidney disease and patients with chronic inflammatory conditions like psoriasis or rheumatoid arthritis are considered at higher risk. So history of premature menopause in females, or history of pregnancy-associated cardiovascular disease or preeclampsia, puts these patients at risk, at higher risk in the future, and that should be looked at when we're going through the past medical history. Certain ethnic groups, such as the South Asian patients, are at higher risk. We can also look at other biomarkers to refine the risk by looking at things like high sensitivity reactive protein, which is a marker of inflammation. And there are other things like the elevated lipoprotein A and ApoB, which you can check in patients with family history of premature cardiovascular disease. And if they're abnormal, that is yet another tool to discuss with the patient before coming to the decision to be as aggressive as possible in treating them. ABI is a non-invasive way of checking for peripheral vascular disease, and that can also be another tool to use. Lifestyle factors affecting cardiovascular risk are many. Again, the ones that we know are class 1, basically start off with a diet emphasizing intake of vegetables, fruits, whole grains, nuts, and fish to decrease risk of cardiovascular disease. Other things that we recommend to our patients where the evidence is there but might not be as strong as the one we just talked about is restricting, basically replacing saturated fats such as lard or with dietary monosaturated and unsaturated fats can be beneficial, things like olive oil. And a diet containing reduced amounts of cholesterol and sodium can also be beneficial. As part of a heart-healthy diet, it is reasonable to minimize the intake of processed meats, refined carbohydrates like flour, and sugar and sweetened beverages to reduce the risk. And we know that intake of trans fats should be avoided because that has been shown to increase the risk of cardiovascular disease. Moving on to exercise and physical activities, adults should be routinely counseled in healthcare visits to optimize physical activity and their lifestyle. This means engaging in at least 150 minutes per week of accumulated moderate intensity or 75 minutes per week of vigorous intensity aerobic activities, or a combination. For adults, the evidence for what I'm about to say is not as strong, but we always want to encourage our patients who cannot reach that goal to do everything in their power to try to stay as active as possible. So if they're unable to meet the minimum physical activity recommendations, engaging in some form of moderate or physical activities, even if it's less than that, is recommended also to help maintain their weight and not gain more weight. So patients, elderly patients with a lot of rheumatologic issues can be, we can advise them to do water activities or swimming as a form of exercise. And decreasing sedentary behavior in adults obviously is something that's reasonable to reduce global cardiovascular risk. In the US, we found that adults spend more than 7 hours on average in sedentary activities, and replacing that with other physical activities involves increasing either moderate to vigorous activity or at least light intensity physical activities. The 2018 physical activity guideline recommended that older adults should do multi-component physical activity that includes balance training as well as aerobic and muscle strengthening activities. And the benefits include not only lowering risk of mortality with cardiovascular risk, but also less risk of high blood pressure, diabetes, and a lot of other forms of cancers were found to be less in more active patients. Additional improvement have been seen in cognition, lower risk of dementia, lower risk of anxiety and depression, improved bone health, and lower risk of falls and associated injuries. This slide is from the Nurses' Health Study many years ago, but it showed that for each 1 hour of daily walking, you reduce your risk of obesity by approximately 24%, and your risk of diabetes by approximately 35%, versus for each 2 hours increment of daily TV watching, you increase your risk of obesity by 23% and diabetes by approximately 14%. And this highlights the importance of reducing sedentary behavior and increasing physical activity. Moving on to other factors. The class 1 recommendations for adults with overweight and obesity. Weight loss obviously is one of the most important things that we as providers need to keep working on with our patients, and counseling and comprehensive lifestyle intervention, including recommending caloric restrictions as the first thing, and then recommending achieving and maintaining weight loss by bringing this up at every visit and making sure that we have goals set that can be achieved. Calculating BMI is recommended annually or more frequently to identify these patients and have the discussion of weight loss. For adults with diabetes, a tailored nutrition plan focusing on a heart-healthy diet pattern is recommended to improve glycemic control and achieve weight loss if needed, and improve their risk factors and decrease their risk of heart disease. In these patients, at least 150 minutes of exercise that's moderate intensity or 75 minutes of vigorous intensity activity will also help improve their glycemic control and achieve weight loss. This is a little bit of a busy slide, but it summarizes a lot of the things that we talked about. And just notice that the base of that pyramid always starts off with the basics of the dietary components and the exercise, and breaking it down depending on the levels of the hemoglobin A1C when you should start considering medication. But just remember that even for patients that are on treatment, we should always be going back to the basics and making sure that they are adhering to the dietary and exercise recommendations. Adults with high blood cholesterol, for the highest level recommendations came in adults at intermediate risk, defined as more than 7.5 or less than 20% 10-year risk. Statin therapy reduces the risk of atherosclerotic cardiovascular disease. And if a decision is made to start this therapy, moderate intensity statins should be recommended. And for me, treating high cholesterol is one of the easiest, but also one of the hardest things to achieve because of a lot of the actual perceptions of the possible side effects that have been attributed to this medication. And you can find it if you go to Google, all over the internet, unfortunately. They are extremely safe medications, and one of the few medications that we have a lot of robust studies that have shown their benefit. And a lot of times I just meet my patients halfway and start them on low intensity statin just to get them on treatment, and then try to advance it if they're not at goal later on. But the guidelines are very clear in what patients would benefit from this and what doses we should be using. In intermediate risk patients, LDL levels should be reduced by 30%. So when you put a patient on the medications, 3 months later, you should check their levels and see if you're achieving the goal that you need. And for optimal risk reduction, especially in patients that are high risk, the recommendations are to be a lot more aggressive and try to bring that down by 50%. Cardiovascular disease mortality in middle-aged people with diabetes is something that we need to also alert our patients to. And studies in those groups have showed in patients living with diabetes in high and middle income countries, up to 27 per 1,000 will die from cardiovascular disease each year, and up to 9 per 1,000 will die from stroke, and 7 out of 1,000 will die from coronary artery disease each year. There was a study between 2017 and 18. It was a multi-country study that wanted to look at basically the awareness of cardiovascular disease amongst patients with diabetes. It was an online survey, but the results were eye-opening for me. And it showed that people with type 2 diabetes underestimate their cardiovascular risk despite the high incidence of cardiovascular events in patients like them. And they relied heavily on their healthcare providers for information and advice, but there appeared to be insufficient dialogue between the medical providers and the patients regarding the cardiovascular risk in diabetics. So 1 in 10 patients did not know about the cardiovascular risk in diabetics. 1 in 4 considered themselves to be at low risk or no risk at all for cardiac disease. 1 in 4 had never had a discussion with their providers about their risk or had that, and 3 in 4 relied on cardiovascular disease information from the profession. So hence the breakdown in communication. And 1 in 6 were unsatisfied with the information they received from their health professionals when they did have that discussion. So adults with high blood cholesterol and diabetics, the recommendations are if you're a diabetic between the age of 40 and 75 years, you do not need to do the estimated 10-year risk calculator, and that you should be initiated on moderate intensity statin therapy because your risk is already higher than the general population. in patients between the age of 20 and 75 years of age with an LDL level of 190 or higher. That's the other group of patients that is high risk, and they should be placed on the highest tolerated statin dose. The evidence is also there for adults with diabetes who have multiple risk factors. It's reasonable to prescribe high-intensity statin and to try to reduce the level of the LDL by 50% instead of moderate intensity statin. And in intermediate risk adults, risk-enhancing factors should be looked at in order to intensify the statin treatment or convince the patient that they need to be on those treatments. One of those tools is coronary artery calcium score, which we can measure. And if the score is 0, it's reasonable to withhold statins from patients and reassess every 5 to 10 years. So this is not a one-time decision. As long as there's no high-risk conditions in these patients, such as strong family history of premature disease, or if they're smokers or if they're diabetic, those patients are at higher risk and should be treated. If your calcium score is between 1 and 99, it's reasonable to initiate a statin in patients above 55 years of age. And if your calcium score is above 100, or if you fall in the 75th percentile or higher for your age group, it's also reasonable to initiate the statin therapy. In patients at borderline risk, in the risk discussion with the providers, the presence of risk-enhancing factors may justify initiation of those treatments. And this is a busy slide, but it shows everything that we've talked about, and it helps you figure out where your risk falls and what other tools you can discuss with your primary care and things in your past medical history to have a better idea where you fall and what treatments are best for you. And I'll point out that the recommendations here tell us that we need to start looking at the lifestyle modification in the pediatric group, because that's when you are going to have the strongest point in making these patients live a healthy, lifelong lifestyle. And a lot of studies have shown in military recruits who died in combat in their early ages, in the 20s and 30s, that the deposition of cholesterol and coronary artery disease starts at a younger age. So we can never start too early. Other risk enhancers in diabetic patients, if they've had diabetes for a long time, that puts them at a higher risk. So more than 10 years of type 1 or 20 years of type 1, and 10 years of type 2. If they have more than 30 micrograms of albumin per milligrams of creatinine in their urine, or if they have kidney function issues, or retinopathy or peripheral neuropathy, or any evidence of peripheral vascular disease. This slide refers to what we were talking about with the coronary artery calcium score. So patients who might benefit from knowing their scores are the ones that are maybe reluctant to start statins and want to understand their risk a little bit better. Patients concerned about restarting a statin who were on statins in the past and had some side effects. And we know that even though we have a lot of different statins, re-challenging patients may be a little bit difficult because they've had side effects to them, but a lot of patients can be successfully started on another statin at a lower dose and increasing gradually, and we can be successful in maintaining them on statins long term. Older patients, men more than between the ages of 55 and 80, and females between 60 and 80 with low burden of risk factor who question whether they would benefit from statin, is another group that we can get a calcium score on to better understand and have a better decision if we should start them on these medication or not. Middle-aged adults with a calculated 10-year risk between 5 and 7.5, with other factors that increase their cardiovascular risk, can use this tool to sway the decision one way or the other. Moving on to patients with high blood pressure. In adults with hypertension, including those requiring medications, non-pharmacologic interventions are recommended to reduce blood pressure. This includes weight loss, healthy diet, sodium restriction, increasing potassium supplements or foods that are high in potassium, and increasing physical activity and limiting alcohol. Also in adults with risk, 10-year risk greater than 10%, whose blood pressure is higher than 130 over 80 or higher, use of medication is recommended to prevent future cardiovascular disease, including strokes and heart failure. And once patients are started on blood pressure medication, the target blood pressure should be a goal of less than 130 over 80 is the latest recommendations. And in adults with high blood pressure and kidney disease, the same thing applies. In patients with type 2 diabetes and hypertension, antihypertensive drug treatment should be initiated at a blood pressure of 130 over 80 with a treatment goal of less than 130 over 80. And some of us are a lot more aggressive and would like the goal to be less than 120 over 80 in this population because of their high risk. In adults with 10-year risk of less than 10% and systolic blood pressure of 140 or higher, or the lower number, the diastolic of 90 or higher, initiation of medications is recommended. And the target blood pressure should be less than 130 over 80. This summarizes what we were talking about. And again, as you notice, the non-pharmacologic therapy should be highlighted no matter what level of blood pressure and whether or not we are treating our patients with medications or not. We should always be discussing the non-pharmacologic therapies. And this slides will go through a couple of things and tells you for about every 1 kilogram or 2.5 pounds of weight reduction, you can expect a drop in blood pressure up to 5 millimeters mercury in obese, in hypertensive patients. And the rest of it is also on the slides, which will be shared later on for everybody. So, for following a heart-healthy diet or a DASH diet and restricting sodium, you can expect to drop the systolic blood pressure anywhere from 5 to 10 millimeters mercury, and the diastolic between 2 to 3 millimeters of mercury. And if you have dietary potassium supplements up to 5,000 milligrams per day, but the recommendations more than pill supplements is to consume diets rich in potassium, such as bananas, cantaloupes, greens, spinach, broccoli. That will also give you about a 4 to 5 millimeter mercury reduction long term. Physical activity, as we discussed, and weight loss, and reducing alcohol consumption, defined as less than 2 drinks per day for men and less than 1 drink per day for females, can decrease the blood pressure. So if you have patients on 2 to 3 antihypertensive medications who are obese and sedentary and don't adhere to a healthy diet, you can try to convince them to do a lot of these things to come off some of these medications, and perhaps if they achieve a ideal body weight, they might be able to stop that completely. But that needs to be followed regularly and not just stopped and continue with that treatment. Last but not least, talking about tobacco, all adults should be assessed at every healthcare visit for tobacco use, and that should be recorded. And to achieve abstinence, all adults who use tobacco should be firmly advised to quit. Aspirin is a topic that comes up frequently. About 20 years ago, we were prescribing low-dose aspirin for primary prevention of heart disease. This is, let me be very clear, when these came in, I think it was in the New York Times or a couple of major newspapers, I had a few patients who have documented heart disease and coronary disease who stopped taking that because they thought that that applies to them. This only applies for patients that don't have coronary disease and want to take a baby aspirin to avoid getting heart disease. We have found after doing studies that a low-dose aspirin for the primary prevention of patients between 40 and 75 years who are at higher risk might give us a benefit, but at a risk of increased bleeding. So if you're not at a high risk, you should not be taking this on a routine basis. And it definitely should not be administered for primary prevention in adults above 70 years of age. So low-dose aspirin, I usually prescribe 81 milligrams, is reasonable in diabetic patients with no previous history of coronary vascular disease if they're at increased risk, meaning 10-year risk more than 10%, based on, as long as they don't have any complete contraindications like history of peptic ulcer disease or GI bleeding, and who are not on other blood thinners. And those patients, so diabetics, and men above 50, women above 60 with one other major risk factor can be prescribed this, but the level is not, it's not a level 1, it's a level 2A. Last slide, this is compliments of my colleague Tricia Gentile with Pima Heart. If you scan this, you'll be able to have a free health risk assessment. It's a simple online tool, and it's downloadable, and you can check your own risk and take that to discuss with your medical providers. So I will stop here, and we can start the next portion of the Q&A.
Thank you so much, Dr. D'dahl. So now we are going to be taking questions. We have one in the Q&A box that I will read. It says, you mentioned tobacco. I am wondering if you have any information on marijuana smoke. As my boyfriend recently suffered a heart attack at 35, he is not a tobacco smoker, but is very frequent marijuana smoker. Would love to hear more. Hope that this question is not offensive or inappropriate. So Dr. D'dahl, what do we know about the effects of marijuana smoke, especially that's going to be coming up more now that it's recreationally legal in our area?
So a pretty controversial topic. Obviously, we have people that are on the both extreme sides of this. We know that medical marijuana in certain cancer patients is extremely helpful, but now that it's the use of it is quote unquote legalized and is used more frequently, we're doing a lot more research on it. And there's been a lot of case studies and small studies from multiple big organizations like the Mayo Clinic, who have already shown the effects, the negative effects of marijuana on cardiovascular heart disease. We've had patients that come in with electrocardiograms that look like they have acute ST elevation MI who have been smoking marijuana on a daily basis or increased use right before they were admitted. And we don't see any coronary disease itself. They have vasoconstriction. But there's a lot more literature coming showing that it is not as healthy. I shouldn't say not as healthy, that it's actually might be causing more harm than a lot of people realized before we started doing the studies. and it's tough to convince a lot of patients to come off of it. I have a couple of young patients who refuse to come off of marijuana who are in their mid 40s and have had heart disease, and I'm pretty convinced that they are in that category that we just spoke about, but they haven't had any luck with their chronic pain management and swear by the marijuana effects when it comes to that. So a lot more research to come. But as of now, kind of like alcohol and tobacco, even though we tell patients to restrict it to less than 2 for males, less than 1 for females, we know that a lot of studies that came up recently say that even at that amount, that long-term, there are cardiovascular risks.
Thank you. The only question we have right now, if you guys have any questions, please put them in the chat box, or you can utilize the Q&A feature at the bottom of your screen. Since I have you, Dr. D'dahl, what are the type of questions people should be asking their doctors? So should they go in? Are there certain questions they should be asking about statins or anything like that that you would recommend asking their doctors?
Sure. One thing I see extremely commonly is patients come in who are in the moderate risk group they come in to see me for palpitations or something that has nothing to do with their risk assessment. But I try to, with each new patient, go through their risk profile and discuss that in detail with them. And one thing I find very commonly is they'll tell you, I don't need a statin because my numbers look good. And then when you ask them if they and their providers have calculated their 10-year risk, they have no idea what I'm talking about. So right now, we don't just look at LDL levels and HDL levels and total cholesterol levels like we did 20 years ago and just base the treatment on that. Obviously, if your LDL is above 160 or 190, that's another story. But for the majority of patients that don't have familial causes for high cholesterol, I think we're doing them a disservice by just looking at the numbers. And there is a calculator that all providers can download on to their phones, and by the American College of Cardiology, and it's called the ASCVD Plus, Atherosclerotic Cardiovascular Disease Plus. And literally, it takes me less than 1 minute if the patients have their lipid panel with them. It takes less than a minute to go through and tell patients what their 10-year risk is, and you'd be surprised how many times they end up on statin because the risk is extremely high. And basically what it looks at, I'll just go through it real quick: age, gender, race, systolic and diastolic blood pressure, total cholesterol, HDL and LDL level, history of diabetes, history of smoking. If you're a smoker, it goes through if you're a current smoker, former smoker, if you quit more than 5 years, or if you've never been a smoker, and then history of high blood pressure, and if you're on blood pressure medications or not. And you hit go, and it spits it right then and there in less than a minute, and opens up the discussion into in a lot more evidence-based way for the patients.
Thank you. We have a question. First, yes, we will be sending out the PowerPoint slides so that you all can take a look at them and really look at the different charts and graphs and everything, because we know we went through it pretty quickly. So you all will be receiving that after this lunch and learn. And then Melissa asked, what is the best way to prepare for an appointment with your cardiologist?
I'm sorry, say that again?
What is the best way to prepare for your appointment with a cardiologist?
So best way is to bring your medication bottles. There's a lot of confusion about medication since we're not all on one electronic health platform. So you can make a lot of good decisions during that visit. If you have high blood pressure, it's always a good idea to check your blood pressure twice a day for the couple of weeks before you go see your cardiologist. So when you go in and if your blood pressure is high, you can share that information with them so they can make a better decision. Bring in your bottles, the blood pressure blood pressure measurements, and basically those are the main things.
Perfect, thank you. We have a question about aspirin. Is low dose prescribed aspirin appropriate when a patient had been identified as having a leaky valve?
No, it is not. So valvular heart disease is not the same as coronary heart disease or atherosclerotic. When we refer to patients with high atherosclerotic cardiovascular disease, we're not referring to patients with valvular heart disease. So you can have a leaky valve, but your coronaries are not obstructive, or you don't need to be on cholesterol medications for them. The patients that have higher risk of cardiovascular or heart attack disease, those are the ones that we're referring to in that calculator. So valvular heart disease is not in itself one of the risks, but you need to calculate the risk for you individually. So you might have valvular heart disease, but if you're diabetic and have high blood pressure and kidney disease, then your risk is high for atherosclerotic cardiovascular disease, and then you might be in that group that will benefit from it. But if you're in the low risk group otherwise, and you just have mitral valve regurgitation because of mitral valve prolapse or something not related to coronary disease, you don't need to be on that.
Perfect, thank you. I have a question about COVID. What are the impacts you are seeing that COVID has had on patients if they've suffered from the virus? What are the long-term effects of the COVID on your patients?
So excellent question, and we're learning as we go. So we know that certain patients will get an inflammatory response in their heart cells that looks like other viruses that we've seen in the past. We know some patients will get strokes, and I've seen a few patients that come in with well-controlled blood pressure for years and who've contracted COVID, and now it's spiked really high. So we also are seeing a lot of patients with no known cardiovascular disease in the past having a baseline elevated heart rate. So fast heart rates coming from what we call sinus node. So it's an appropriate response to the inflammation that their body is trying to fight. But we've also seen irregular heart rates like AFib and supraventricular tachycardia, especially in the sicker patients who are in the hospital. So it's affecting the cardiovascular system globally. And a lot of patients are still having persistent dyspnea and chest discomfort months afterward, despite full workup not revealing necessarily anything that we need to place them on specific cardiovascular treatments for. And those are a little bit of a dilemma, and we're still looking at what's the best ways to do that. But baseline, cardiovascular evaluation should be done in those patients. Some, EKG, or some of them might require an ultrasound of their heart if our suspicion that they might have decrease in their heart function. So it's not extremely common, but it's we're seeing it more and more, and we should be very careful with that.
Yeah, okay. We have a question about diets. What is your opinion on the quote unquote bad diets, such as like Whole30 or keto or paleo? How should people be dealing with those diets? Are they healthy? Should people be pursuing them?
So I personally am not a fan of them. I know a lot of patients are, so I try not to cringe when they bring them up. But basically, if you are looking for sustainable weight loss, the only way to do this is with changing lifestyle habits. And doing things that you know that you will be following long term. What I recommend to my patients first is calorie restriction. The 2,200 calories per day, in my opinion, is a high number. I think we should try to restrict it to 1,500 calories. And for people that exercise vigorously, a good way of looking at this. So on the days that you burn 400 calories doing, high intensity training or 30 minutes on a stationary bike, you can give yourself half of those calories back, so up to 1,700 that day. Avoiding any processed food, avoiding beverages. Sodas are notorious. Avoiding trans fats, as we discussed. And, I'm a big fan of mixed nuts, but they are extremely high in calories. So again, in moderation. And we all underestimate when we're trying to look at the amount of calories we're consuming. I don't think we're good at estimating those calories well. So looking at calculators, there's a lot of apps that will be an eye opener to us, is a good way to do this. So fresh fruits, vegetables, lean meats once a week is okay, in my opinion. Salmon, and especially broiled or grilled once or twice a week is the way to go. And there's a lot of studies that go back and forth, but I'm a fan of the Mediterranean diet, especially using olive oil to supplement instead of other butters and margarines is a good way to look at things.
Thank you. So I don't see any other questions. So I am going to leave you with one more. And what message would you like to give to people about seeing their providers? We've seen a drop in people seeing their doctors, especially during COVID. So is there anything that you would like to say about that and the importance of actually knowing your numbers and getting out there and seeing your doctor?
So, luckily, we're looking like we're finally in the right trajectory with the pandemic. If you are having symptoms, I think that you should not postpone seeing your providers. Most of us have the ability to do televisits now, and that can be kind of a triage visit. If your providers think that you need to come in to get an EKG or other testing, I think the risk is acceptable now. Adhering to the all of the recommendations, the mask, the hand washing, etc. But if it's a routine visit and you're completely feeling fine, you can do televisits once a year to fulfill that. I'm seeing a lot of patients actually with symptoms that they've had 2 to 3 weeks earlier, and the damage is done, and they were extremely hesitant to go in. So the recommendations, if you're having symptoms, to reach out to the providers, and a lot of the providers are comfortable telling you, let's do this over tele. This seems like something straightforward, or we need to take this a lot more seriously. You need to come in and be seen in person.
Thank you so much, Dr. D'dahl. We truly appreciate this. I am going to now pass it back over to Mackenzie with the American Heart Association so she can close us out.
Thanks, Teresa. Thanks, Dr. D'dahl. And a big thank you to all of you for being with us today. Pima Heart and Vascular, thank you for coming along the AHA to make today possible. And again, Dr. D'dahl, that was a really engaging and informative presentation. And as Teresa mentioned, we'll be sending it out to each of you so that you have that and you can dive a little bit deeper if you'd like. Also, if you have any other questions, please feel free to email us at the address on the screen. So you can reach out to teresa.shami@heart.org. And then we invite each of you to join us. We have our upcoming Heart Walk. Many of you may have joined us at Reed Park in past years, where we'd have 4,000 or 5,000 people. This year we will be digital once again, so everyone will be able to walk where they are. It's taking place on April 24th through Facebook. Feel free to register at TucsonHeartWalk.org, and you can follow us on social media at AHA Arizona to join in. And last but not least, if you have any specific questions regarding the Heart Walk, please reach out to our Heart Walk director, Kathy Wood, and her email address is also listed on the screen. Once again, thank you all for joining us and have a great day.